So this is a very complex diagram. It represents what is going on with the atrial and ventricular pressures and volumes while also incorporating the jugular venous pulse and the electrocardiogram. Doesn't matter, we're going to dominate this diagram step by step. If you see the phases labeled at the top of the diagram, starting with atrial systole, this is how we are planning our attack. So we start with atrial systole. Let's begin with the electrophysiology and work our way up the diagram. Remember, P wave represents atrial depolarization. How does this correlate to the A wave in the jugular vein? Well, the jugular vein is draining into the superior vena cava that is emptying into the right atrium. There is no valve between the jugular vein, superior vena cava, and the right atrium. So any changes in pressure of the right atrium will be reflected all the way back up to the jugular vein. You can just think about it as just one continuous column from the jugular vein, the superior vena cava, and into the right atrium. Now, anytime your atria depolarize and contract, there will be a buildup of pressure that is transmitted all the way back into the superior vena cava and then into the jugular vein. Remember how we discussed that you can hear an S4 during this period of atrial systole. More importantly, do you remember the pathophysiology behind an S4? That's the A wave again, and the S4 pathophysiology is due to atrial systole pushing blood into a non-compliant ventricle, causing turbulent flow, which you can hear with a stethoscope on physical exam. So what is happening in the aortic and left ventricular pressure tracing? Not really too much going on here, so do not worry. Let's take the next step and examine what is going on during the QRS period, which represents ventricular depolarization. So we have depolarized our ventricles, causing contraction of the ventricular myocardium. Increased pressure in the left ventricle will slam the mitral valve shut, and that is represented by the arrow here on your diagram where the mitral valve closes. Then we have a period of isovolumetric contraction, represented by the black line, until finally you exceed the pressure in the aorta, which means that you will swing open the aortic valve, and we have the opening of the aortic valve at this period in time, represented by the black arrow. Do you remember how we discussed this in the pressure volume loop? You can look down to trace the decrease in ventricular volume that occurs immediately after the aortic valve opens. So as there is an increase in pressure, represented by the yellow line, there ought to be a decrease in the ventricular volume. So what tracing could you see in the jugular venous pulse tracing if you were measuring right heart function? Well, you could see a little tiny C wave. It's an actual upward deflection. An upward deflection in the JVP tracing means that there's actually a small increase in pressure. This means that the right ventricle is contracting to eject blood into the pulmonary artery, right? Correct. Well, at one point in time, there actually has to be compression of blood in the chamber, just like there's isovolumetric contraction that we mentioned in the left ventricle. Remember, the right ventricle flows into the pulmonary artery across the pulmonic valve. And also, it's going to push up against the tricuspid valve, causing a slight tenting or bulge of this tricuspid valve into the right atrium. And that is your C wave, or small upward deflection in the jugular venous pulse tracing. The compression of the blood pushes up against the inferior aspect of the tricuspid valve. This pushing against the closed leaflets of the tricuspid valve is recorded as a small upward bump in the pressure tracing, which is represented by our C wave. This makes the tricuspid valve leaflets kind of balloon up, but not enough to cause any regurgitation. Then they relax to be completely flat, which is why it decreases immediately afterwards. This return to normal after closure is the X descent, which corresponds to the pressure dropping in the right atrium, and therefore the jugular vein. We see S1 during this period of time because we just discussed how we are contracting our ventricles and therefore will cause the atrioventricular or mitral and tricuspid valves to slam shut because we are increasing the pressure of our right and left ventricles, therefore causing the mitral and tricuspid valves to close. This is represented as S1 in your diagram. Now, we move on to the next step. Eventually, the pressure in the aorta exceeds that of the left ventricle. The aortic valve closes, represented by the black arrow. So what is this dichrotic notch that is represented on the diagram? This isn't necessarily the most important detail, but I would personally like for you guys to have the chance to learn this, considering I was never told the physiology of what exactly was going on here. So as the velocity and flow of blood entering the aorta decreases, there will eventually be a period of time when you have no flow, and there will actually be even a slight bit of regurgitation into the left ventricle. It is a negligible few milliliters, but the fact that flow is reversed means that we slightly increase the volume of blood in the left ventricle. Milliseconds after the valve closes, this newly regurgitated blood pushes up against the inferior aspect of the aortic valve leaflets. So again, the aortic valve leaflets have a little bit of increased pressure sensed from the inferior aspect of them. This is rather similar to like what we saw occurring with the tricuspid valve when we were discussing the C wave in the JVP tracing. So this pushing of blood against the inferior aspects of the aortic valve leaflets causes a slight jump in the pressure of the aorta, which is on this side. There will be pushing towards the aortic pressure reading. Eventually, these valve leaflets will return back to normal, and you get a diacritic notch because of this really quick increase and then decrease in the aortic pressure reading. We can now let go of the aortic pressure reading because there will not be anything happening as the pressure in systole drops down to the pressure recorded in diastole. Let's look at this little spike in the left atrial pressure tracing that occurs here. Take a pause here and try to figure out why this little jump is present. That is followed by a sudden decrease. There's a small increase and then decrease. Remember how I told you that some of the blood from the aorta regurgitates slightly into the left ventricle and causes a bulging of the aortic valve? Well, if you fill that left ventricle to capacity, that represents that. This left atrial pressure tracing also resembles what was going on with the diacritic notch. There's a little bit of regurgitated blood that causes an increase in the volume of the left ventricle, and that pushes also on the inferior aspect of the mitral valve leaflets. And that causes an increased pressure tracing, followed by the valves returning back to normal, so they pouch up a little bit, and then they return back to normal, and that is your descent. S2 occurs in this segment because it is the closure of the aortic and pulmonary valves. We just discussed how the increased aortic pressure over the pressure in the left ventricle will cause the aortic valve to slam shut. The aortic valve leaflets are trying to move in the direction of the decreased pressure, which is in the left ventricle. Now what about the V wave? The V wave in the JVP tracing corresponds to filling of the right atrium. We forgot to mention the T wave here that represents the ventricular repolarization. This seems kind of off because if you look higher up the diagram, you see that it is placed in a spot where the ventricular volume is still decreasing in the segment. But this is actually just because the electrical changes that are occurring in the repolarization are one step ahead of the contractile forces that are changing the volume and pressure tracings. Remember, once you depolarize the muscle and increase the calcium in the cells, you have an all or none phenomenon. The last block of this diagram we're going to break down is diastole. In diastole, we need to have, first of all, the opening of the mitral valve so we can fill that left ventricle. You can see here that the left atrial and left ventricular pressure tracings match up. That should make a lot of sense, right? There is no mitral valve separating the two chambers, so you can consider it one continuous chamber. So the mitral valve leaflets are open. The left atria is directly connected with the left ventricle. So the pressure tracing of these, you can consider it one column. It should be the same. Again, in this section, we see an S3 popping up right when the mitral valve would be opening. Can you remember what an S3 is caused by? That would be the rapid filling of the ventricle as soon as the valve opens, allowing blood to hit that ventricular wall, making it expand very quickly. When this blood smacks against a non-compliant wall, you can actually hear an S3. So as we see blood rushing in, it can smack against this ventricular wall, causing a potential S3 heart sound. Sometimes this is non-pathological because it can occur in young individuals that exercise a lot, or pregnant women that have high plasma volumes. So consider the population if you are being asked a question on this. The last element that we need to discuss is in the JVP, to the Y slope. What does this represent? Remember, both atrioventricular valves are wide open right now, allowing the emptying of blood from the left and right atria into the respective ventricles. So there will be now more room in the atria for blood to be emptied from the jugular vein via the superior vena cava. This is why you see a downslope in in the jugular venous pulse because blood is being emptied into the atrium. Before we discuss splitting, let's quickly review the definitions of S1 and S2. The S1 heart sound is created by the closure of the atrioventricular or mitral and tricuspid valves, and the S2 heart sound is composed of the closure of the aortic and pulmonary valves. So the mitral valve usually closes a little bit before the tricuspid valve, but the difference is so small that to the human ear you will never really hear the two separately, unless for some reason you had a significant pathological condition like bundle branch block that limits one ventricle from contracting in synchrony with the other. On the other hand, the separation of the S2 heart sound is a little bit larger and can actually vary depending on respiration, specifically increasing the time between aortic and pulmonic components on inspiration. So how does taking a deep breath cause the S2 heart sound to be heard into its two individual components? This is an incredibly important concept because it tests your understanding of chest wall physiology. Now remember, thorax is a closed system. So when you take a deep breath and you expand this space, you create a negative pressure inside the thorax because you're pulling these components out, causing an expansion of whatever vessels or structures are within the thorax. The diaphragm moves inferiorly, and the accessory respiratory muscles can also help expand this chest wall to achieve this overall function. Now what does this do? Let's review. It creates an intrathoracic negative pressure. So what does this negative intrathoracic pressure do to the compliance of the pulmonary vessels? Think back here to what compliance actually means. Compliance is the relationship between what a change in volume would do for a given change in pressure. So this increase in negative intrathoracic pressure means that we will decrease some of the transmural pressure on the pulmonary vasculature. So this is a pulmonary vessel, and the negative intrathoracic pressure will help alleviate some of this transmural pressure, in addition to the expansion of the lungs, opening up some of the capillary networks. This allows the pulmonary vasculature to hold a lot more blood because we have opened some capillary networks and decreased some of the resistance of the pulmonary vasculature. Because that right ventricle and that right atrium are directly connected with the pulmonary vasculature, this will help pull more blood to the right side of the heart. Remember, the venous return is the venous pressure minus the right atrial pressure. And this increase in negative intrathoracic pressure will further decrease the right atrial pressure, causing an increase in venous return. So try to break it down into this very simple way. If you create a negative pressure in the thorax, you are removing some of the pressure on the vessel walls within the pulmonary circulation. Just think about it like you're subtracting some of the pressure by applying a vacuum directly to the outside of the vessel walls. This allows the pulmonary vessels to expand much more easily without having such an increase in pressure. So what happens when vessels can expand much more easily due to an increased compliance? They can store much more blood. So we have a very compliant vessel with the help of the inspiratory induced negative pressure. Now we have a situation in which we need more volume to create the same level of pressure that will push back on the pulmonic valve and close it. Do you think it takes more blood and time to increase the pressure to the same level within these pulmonary vessels that now have increased capacitance? Of course. So there will be more blood flowing over that pulmonic valve. These are your pulmonic valve leaflets, and this is the pulmonary artery. So there will be more time and flow of blood across those pulmonic valve leaflets. In addition, you will have an increased amount of time of this flow across the pulmonary valve leaflets, but your pulmonary vasculature will ultimately restore more blood, and this will prevent return of blood to the left side of the heart. And this means that there will be less flow across the aortic valve, and that actually will even further shift your aortic valve component to occur earlier. This is not demonstrated in the diagram, but this further shift to earlier component and this P2 now occurring later means that your split, or the occurrence of the aortic and pulmonic component of the S2 heart sound, will be more audible because the distance and time between the two is much greater. So the increased capacity of the pulmonary vessels means that more blood is stored in the vessels. So guess what is now going to receive less blood? the left atrium. This causes reduced filling of the left atrium in the ventricle, which means your preload or end diastolic volume is less. So quick summary here. On inspiration, you have an increased gap between the aortic and pulmonic components of the S2 heart sound. The aortic component, A2, comes earlier, and the P2 component, or pulmonic component, is shifted and occurs later. The increased compliance of the pulmonary vessels allows them to hold much more blood at lower pressure. This causes the right side of the heart to be able to pump more blood, keeping the tricuspid valve and the pulmonic valve open for longer periods of time because they're handling more volume of blood. And the left side of the heart will not receive as much blood from the pulmonary vessels, which means that it takes a shorter amount of time than you would normally expect to push the expected stroke volume over the aortic valve, making the aortic valve close earlier because we have less blood flowing over that valve. Your slide only shows the shift of the pulmonic component to the right. So don't forget that the A2 component actually occurs earlier because we're delivering less blood to the left side of the heart because the pulmonary vasculature is holding more of it. So again, as you can see, this increased gap shown by the arrow. Now what about a paradoxical split? Let's discuss the three other types of splitting: wide, fixed, and paradoxical. Wide splitting is a relatively easy concept. Wide essentially means that the gap between the aortic and the pulmonary components increases. Does the aortic valve close earlier, or does the pulmonic valve close later in the situation of a wide split? Usually there is pathology going on with the right ventricle, causing the closure of the pulmonic valve to be abnormally delayed. So a wide split usually has some sort of pathology with the pulmonic valve, and it is more prominent on inspiration due to the increased negative intrathoracic pressure's effect on the pulmonary vessel capacitance. Now what are some things that could cause the delayed closure of the pulmonic valve, causing a wide split? Well, just think about it. To close that pulmonic valve, we need to pump blood into the pulmonary artery, causing increased pressure in the pulmonary artery, so that there's now a pressure gradient where the pulmonary artery pressure has increased greater than the right ventricular pressure. Therefore, this would close the pulmonic valve. So anything that causes that delayed contraction of the right ventricle, such as bundle branch block or some intrinsic pathology of the valve itself, such as pulmonary valve stenosis, will inhibit that valve from closing. So next up, we'll discuss some paradoxical splitting. Let's compare the two because you have physiologic and paradoxical splitting. Remember, unless something is wrong with the heart, you should always expect the aortic component of the second heart sound to occur before the pulmonic component. Would you consider it really confusing if these reversed, with the pulmonic valve sound coming before the aortic sound? I'd say so. I might even go as far as to call it paradoxical. So take a second here and think. What are some reasons that would cause the reversal of the order of the aortic and pulmonic heart sounds? Let's say that someone had an MI and some of the cells in the conducting part of the left bundle branch died. So the left bundle branch, those cells died. The impulse cannot travel through the bundle branches on the left side anymore. Instead, the depolarization of the right ventricle, which is completely fine, the right bundle branch is intact. Now we must use the gap junctions that we could discuss with our connexons to travel via cell, via cell, via cell, all the way over to depolarize that left ventricle. So the impulse cannot travel through the left bundle branch anymore. It must travel through the right bundle branch, depolarize the right ventricle, and then the depolarization of the right ventricle now must travel via gap junctions from the right ventricle all the way across to eventually depolarize the myocytes in the left ventricle. Cell-to-cell myocyte conduction is so much slower than if you were using that super highway of the bundle branches. So why am I telling you this? Well, if the right ventricle depolarized much more quickly than the left ventricle, because nothing is wrong with the right bundle branch, the systolic period will end much sooner on the right side of the heart than the left. This translates to the closure of the pulmonic valve much sooner than the aortic. So we have a switching of the aortic and pulmonic components, which is termed paradoxical because it's not what we normally expect. Now, what about the last one, fixed splitting? Fixed means that no matter what you do, you can hyperventilate like you're having a panic attack or take slow deep breaths. The interval between the aortic and the pulmonic component will not change. It is fixed permanently. And what is the most common cause of this? That is your ventricular septal defect. So rather than just tell you it's a VSD, let's just kind of think about what is happening with the VSD to make the two sounds that always occur at the same interval apart, no matter where in the respiratory cycle we are. So remember, an ventricular septal defect, which is most commonly due to a defect in the membranous component of the interventricular septum, causes a left to right shunt. Blood that should be in the left ventricle is shunting across to the right ventricle. This means that we will have increased flow through the right ventricle, and means we will have a decreased volume flowing across the aortic valve. So again, this VSD causes a left to right shunt, causing more flow in the right ventricle, which means increased flow across the pulmonic valve and a decreased flow across the aortic valve. No matter if you change the intrathoracic pressure or not, this shunt will be maintained, and so will the split. This can also happen with an ASD because all you need is some sort of abnormal communication between the left and right side of the heart that increases the volume of blood on the right. But you most commonly will see it with a ventricular septal defect because the pressure gradients between the left and right ventricles are much more profound in comparison with the pressure gradients between the left and right atrium. And usually the defect in a ventricular septal defect is much larger than the defect in an atrial septal defect.